Hi everyone, I'm Aoife McVeigh. I'm a Urology Research Fellow at the Austin Hospital, and thank you for the opportunity to present our research on the evaluation of urodynamic findings in patients with a history of transurethral resection of prostate and persistent lower urinary tract symptoms, which I've completed under the guidance of Dr. Garson and Mr. Johan. We have no affiliations to disclose, and this is a self-funded study. Just a bit of background on our topic. Lower urinary tract symptoms are a significant healthcare burden worldwide, and up to 2/3 of men over the age of 40 do report LUTS of some sort. There are various causes for male LUTS. Commonly it's bladder outlet obstruction, which can be secondary to benign prostatic hypertrophy, but there are various other non-prostatic etiologies, including detrusor overactivity and detrusor underactivity. BPH treatment has got a substantial financial burden to healthcare systems, about 180 million British pounds per year in the UK and up to $1.1 billion in the US. A typical investigative workup for LUTS includes careful history, examination, use of symptom scores, including IPSS, and various imaging techniques and Euroflow testing. Pressure flow studies, including video urodynamics, are not recommended in the initial investigative workup, but are in certain circumstances. And there is actually a rate of persistent LUTS post-TURP can be as high as 35%, and often another cause for the symptoms beyond the original BPH can be found. The aim of our study is to identify the etiology of persistent LUTS by evaluating urodynamic findings in patients who've had a previous TURP. In terms of our study design and methods, it included 1,431 patients that had been referred for physician-performed video urodynamics between 2013 and 2019 at our centre, and institutional ethics approval was obtained prior to our study. We had an inclusion and exclusion criteria defined as inclusion criteria of persistent LUTS with a history of TURP, whether this was a traditional TURP or green light laser photovaporization of prostate, and we excluded patients that had a prostatic malignancy, prostatectomy, or had incomplete data. Overall, after applying this criteria, we had 106 patients that met the inclusion, and from these patients we collected data and analysed on the patient demographics, symptoms, cystoscopy results, video urodynamic parameters, the diagnosis found and suggested treatment outcomes. We then went on to do some subgroup analysis according to time since the patient had their prostate surgery, and that was divided into Group A and Group B, Group A being less than 2 years and Group B being greater than 2 years. Just an overview of the study group demographics. There were 106 patients, as I previously mentioned. The median age was 73 years. Average time interval from TURP to urodynamics was 45 months. The majority of patients had a traditional TURP at 86%, and the rest had a green light laser at 14%. The majority of patients actually presented with mixed voiding and storage symptoms at 61%, with pure voiding at 29% and pure storage symptoms at 10%. And then on subgroup analysis, according to time since TURP, Group A represented 43% of the study group and Group B was 57%. And here is just a table summarising the urodynamic findings of the study group and dividing it according to the subgroup analysis of time since TURP. And you can see that the most common diagnosis was detrusor overactivity, or detrusor underactivity, which is 31% of the population group, and detrusor overactivity following it at 29%, and various other causes were found, and actually 98% of patients did have a diagnosis or etiology reported on the urodynamics by the physician performing. We did find though that there was no statistical difference between the diagnosis rates of detrusor overactivity, detrusor underactivity, or bladder outlet obstruction according to time since TURP. Here's a table describing the suggested treatment outcomes for our patients. So 45% actually required further surgery or were recommended to have further surgery. 12 of these were for a redo TURP. A big proportion were suggested to have further Botox, and 18 were suggested other treatments, for example, sacral nerve neuromodulation, dilatation for strictures, artificial urinary sphincter. 24% of patients we suggested an ISC or long-term IDC, 26% required medical treatment, and 4% were their urodynamics were either normal or inconclusive, and no further treatment was suggested. In our study, we did find some significance to the PVR result. In particular, we used the 200 ml cutoff to determine whether or not they had a low or high PVR. So patients that had a PVR of greater than 200 mils, which should be actually 34, and patients that had a PVR of less than 200 mils, which should be 20. The patients with a high PVR were more likely to be diagnosed with detrusor, some form of detrusor underactivity, compared to those with a PVR of less than 200 mils, and the p-value for that was 0.00064. So the key findings are that the etiology of LUTS post-TURP is multifactorial and complex. The majority of patients were presenting with mixed storage and voiding symptoms, and the vast majority did have an etiology found in urodynamics. A high proportion had detrusor overactivity or detrusor underactivity, and patients with high PVR were more likely to have a detrusor underactivity finding. And as a conclusion, we suggested that this study highlights the potential strength in the utility of urodynamics as a diagnostic tool for the investigative workup in patients with refractory LUTS post-TURP. Of course, there are limitations to the study, the main one being the study design. It is retrospective, a small study size. There's variation in medical documentation and also potential for confounding factors. And in particular, it's unclear whether or not the patients had the diagnoses that we found before or after treatment. Thank you very much for listening, and we're very happy to answer any questions that you might have.